comorbidities and mental health in adults with epilepsy. We have three excellent speakers: Mula from London, Arjune from Oxford, both in the UK, and Simona Lattanzi from Italy. Please note that we will have the three presentations, and then we will have a question and answer session at the end. If you have questions, you can type them into the question and answer button at the bottom of your screen. However, we're not able to respond to questions referring to a specific case or patient. We want to acknowledge the support of our eForum series from unrestricted educational grants from UCB, who are a gold supporter, and Jazz Pharmaceuticals, a bronze supporter. Really grateful for that. As I said, if you can type your questions into the Q&A box, so I can address those to the panelists in the last half hour of the eForum, and we'll hopefully have a lot of discussion. You will be asked to complete a short survey at the end of the eForum, and it'd be really great if you could complete this so that we know where we can go with the eForum in the future. So without further ado, I'd like to introduce our first speaker, Mula, a consultant neurologist from St George's Hospital in London. And he is going to talk about psychiatric disorders in epilepsy. Thank you, Marco.
Thank you, Helen. Thank you very much for inviting me to this ILAE forum series. This is my disclosure. What I'm going to discuss with you is, after a brief overview about the concept of comorbidities in general in epilepsy, the specific topic of psychiatric disorders in epilepsy, looking at the epidemiology, the nature of the relationship between epilepsy and psychiatric disorders, and why are they relevant to the neurologist. The main change in the concept, we will start with a very brief case, that is the case of Paul, 24 years old, right-handed man with a onset of the epilepsy around age 21 when he suffered his first tonic-clonic seizure. That time was investigated in a first seizure clinic. MRI and EEG were normal. After a year, he had the second tonic-clonic seizure, was started on lamotrigine. Lamotrigine was gradually titrated up to a dose that is currently 250 milligrams twice a day. But in the subsequent 3 years, a couple of years, he had 3 more seizures, with the last one 3 months before the appointment with you. He had a repeated EEG showing some right frontotemporal epileptic abnormalities. The MRI remained normal. Normal birth, normal developmental milestones, no history of febrile seizures. He's never used recreational drugs, drinks alcohol moderately, works in computer science. He then does not report any compliance issue. No family history of epilepsy, no family history of neurological disorders. There is a family history of psychiatric disorder, a sister with anxiety and depression. In his past medical history, he suffered asthma as a child. He has a diagnosis of depression. He had his first depressive episode age 18, initially treated with CBT only. He remained euthymic for a couple of years, but then he had a relapse age 20, just a year before the onset of the epilepsy, when he was started on sertraline by the GP. Sertraline was gradually increased to the current dose of 75 milligrams, and he reported to be stable. So quite an easy case from an epilepsy point of view that many of you may encounter, also general neurologists. So look at these 3 statements and think which of the 3 is right. Paul has an increased risk of having drug-resistant epilepsy. Paul has an increased risk of side effects from anti-seizure medications. Paul's life expectancy is probably reduced by almost 15 years. This obviously compared to an unselected sample of people with epilepsy. So vote now. Okay. Okay, fairly divided between the first and the second statement, and just a few, a couple of people, the very last one. So unfortunately, all the three of them are quite right in this specific case, and then we will see why. So the concept of comorbidities in epilepsy had definitely the acknowledgement with the new ILAE classification of epilepsy syndromes, because in the new multi-axial classification of epilepsies, apart from the epilepsy type, the syndromes, there is also mention of all the different etiologies and also all the comorbidities that become an integral part of the definition of the individual syndrome and type of epilepsy of the individual patient. But the concept of comorbidities was introduced many years ago by Alvan Feinstein in 1970 and had an absolutely neutral meaning, because it was just an epidemiological index in order to understand in epidemiological studies about the co-occurrence of different clinical entities in the same patient, but without any understanding of the potential relationship between these conditions. It is now evident that epilepsy is a system disorder that is characterized by seizures, but also by a number of systemic problems. 50% of adults with active epilepsy have at least one comorbid medical condition. Medical conditions in general are 8 times more prevalent in people with epilepsy than in the general population, and they represent the large majority of direct medical costs of the epilepsy itself. They hugely contribute to the hospitalization of people with seizures, and especially the causative comorbidities represent the large majority of causes of death during the first year since the onset of the epilepsy itself. Now, when two conditions happen at the same time, there may be a number of reasons, so usually due to the interaction between individual predisposing factors due to our genetic background and predisposition interacting with the external environment. Now, in epilepsy, we can identify 5 major mechanisms that can lead to a comorbid condition. The first one is very simple, a causative relationship. So one is the cause of the other, like, for example, the co-occurrence with some infection conditions or a stroke or traumatic brain injury. Others have a reciprocal mechanisms, so a sort of bidirectional relationship where one seems to increase the risk of developing the other and vice versa. This has been seen in a number of psychiatric disorders, but also in diabetes, for example. Then a mutual mechanism where two conditions share exactly the same etiology, like, for example, in tuberous sclerosis, where the same mutation can lead to a number of different conditions, or in some heart diseases, especially for potassium channel mutations. Then we have resultant comorbidities that are the consequence of the anti-seizure medications or the consequence of seizures themselves. And then coincidental comorbidities that happen by chance. For psychiatric disorders, it has been long recognized that the relationship between epilepsy and psychiatric disorders was complex. Hippocrates 2,000 years ago already alluded to the possibility of a shared neurobiology between epilepsy and depression. And even more interestingly, 4,000 years ago, the Assyrian doctors already postulated that people with a long history of epilepsy could develop psychosis. I'm sure that many of you have read this very nice report from Ted Reynolds about this Assyrian medical text that is still present at the British Museum. The interesting thing is that James Wilson, who was an Assyrologist, a British Assyrologist, was also the youngest son of Samuel Wilson, the neurologist who described Wilson's disease. Now, the practical definition of epilepsy in 2014 has recognized now that psychiatric comorbidities and all the cognitive and psychosocial consequences of having epilepsy are part of the condition itself. We now have also very good epidemiological data about how prevalent these conditions are. They are definitely more prevalent than psychiatric disorders in other chronic medical conditions. For example, as compared to diabetes, that is another young onset chronic medical condition characterized by the need of daily treatment and also the risk of potential episode of loss of consciousness. This means that psychiatric disorders are not simply due to having a chronic medical condition with a number of social limitations. For depression, we have meta-analytic evidence that depression is frequent, and 1 in 4 people have active depression, meaning symptomatic in the last 12 months. And this is almost 3 times more frequent than in the general population. For psychosis, we also have very strong meta-analytic evidence that especially for temporal lobe epilepsy, the prevalence of psychosis is almost 7 times higher than that reported in the general population. For children, the emphasis is mostly on developmental disorder. 1 in 3 kids have ADHD, 1 in 5 have autism. But as pointed out by this cohort study from Southwest England, a number of psychiatric disorders are represented in children, but they are most of the time underdiagnosed, because when compared to assessing these kids with structured interview, even depression and anxiety were definitely underdiagnosed, but they are more prevalent than in the normal population of children. This means that in many patients, these problems are diagnosed only when they are severe enough to reach medical attention. What is special about the relationship between epilepsy and psychiatric disorders? People with epilepsy are obviously at increased risk of mental health issues because of the psychological factors associated with having a highly stigmatized chronic condition, the unpredictability of seizures, sometimes the overprotection by family or the low self-esteem. But obviously, these factors are not enough to explain such a high prevalence, and especially because this prevalence has been described in a number of different cross-cultural contexts. So there are obviously some factors that are related to the neurobiology of the epilepsy itself and the involvement of specific brain structures. What has been pointed out in the last 10 years is that this relationship between epilepsy and psychiatric disorders is not necessarily unidirectional, because not just people with epilepsy are at increased risk of developing psychiatric problems, but these psychiatric problems can precede the onset of the epilepsy, sometimes for a long time. And some psychiatric disorders seem to be associated with an increased risk of developing the epilepsy during the course of the disease itself. This is one of the several studies that Dahles-Dorfer published in the last 10 years, showing this bidirectional complex relationship between epilepsy and psychiatric disorders, preceding the onset of the epilepsy by almost 3 years. And this was observed only with schizophrenia and with autism. These are data from a more recent cohort study from Scandinavia, where they showed that this increased prevalence dates back to almost 20 years before the onset of the epilepsy itself, reaching the climax, the highest peak, just before the onset of the epilepsy. Looking at this graph, it is possible to speculate that probably there are a number of cumulative changes happening in the brain that they may subsequently lead to the development of one condition or the other in a synergistic way. We have some data in that sense for depression because two well-known neurobiological mechanisms of depression, like the low serotonin neurotransmission or the hyperactive HPA axis, seem to be also pro-convalescent and implicated in epilepsy. The majority of animal models of epilepsy are characterized by low serotonin levels, mutation in some serotonergic receptors associated with low seizure threshold, and a hyperactive HPA axis is associated with damage of hippocampal neurons, especially CA3, downregulation of GABAergic receptors, and reduced BDNF and neurogenesis that can ultimately lead to the occurrence of spontaneous seizures. From a brain network point of view, many of the networks that have been identified in depression involving the hippocampi, the amygdala, the dorsolateral prefrontal cortex are exactly the same key structures that are involved, for example, in temporal lobe epilepsy. So now, why should we pay attention to all these factors that can be definitely interesting from an academic point of view, but do they have any clinical implication in our everyday practice? Well, it is now recognized that psychiatric disorders may represent an important marker of disease severity and prognosis of the epilepsy itself. For example, if we look at the prevalence of depression in seizure-free patients, it is pretty similar to that of the general population, but it increases in unselected patients with epilepsy, becoming even higher in people with drug-resistant epilepsy. Psychosis may be considered a marker of severity of temporal lobe pathology because while the prevalence in an unselected sample of people with temporal lobe epilepsy is still higher than the general population, but in patients with abnormal temporal lobe structures, like in unilateral hippocampal sclerosis, even more in bilateral hippocampal sclerosis, is definitely higher. We also have a number of epidemiological evidence showing that people with epilepsy and psychiatric disorders have a 4 times increased risk of drug resistance, 5 times increased risk of SUDEP, increased mortality due to injuries or suicide, increased side effects from anti-seizure medications, not just psychiatric side effects or cognitive side effects, but also somatic side effects. And also poor outcome after epilepsy surgery, although this is still a controversial topic. We now have also more research into this area, trying to understand why people with epilepsy and psychiatric disorders seem to be more drug resistant, and this resistance seems to be very evident since the onset of the epilepsy itself. But we have, unfortunately, now also have data about the impact of psychiatric comorbidity in terms of life expectancy. This is a very nice paper from Jakob Christensen group showing the burden of psychiatric comorbidities in terms of life expectancy. If, unfortunately, having active epilepsy is associated with 11 to 12 years lost, having epilepsy and the psychiatric disorder is associated with 13 to 16 years lost. What can we do? There are a number of things that we can do in our everyday practice. One is related to medical and nurse workforce, becoming obviously more skilled and expert in identifying these problems, and then a number of education resources and health resources for patients and their family in order to empower them to deal with these problems. So obviously neurologists need to become familiar with the screening instruments, able to identify scenarios, what can contribute to the onset of this condition, follow standard care for psychiatric disorder and in their area and try to adapt them to individual needs of their patients, becoming more familiar with the use of first-line psychiatric treatments, especially for mood disorders, becoming more aware about interactions and side effects, and also inform patients, establish partnerships with mental health services and patient support organization in order to direct them to the correct specialist or to self-help groups if available, and obviously advocate for access to mental health resources for people with epilepsy, because still today people with epilepsy have reduced access to mental health resources. So to conclude, psychiatric disorders are frequent. Unfortunately, 1 in 3 adults with epilepsy have an active psychiatric disorder. The etiology is multifactorial due to a combination of individual predisposing factor, having a specific epilepsy or brain network involved, and also psychosocial factors. The relationship is complex, is not necessarily unidirectional, and it is important for the future to try to understand if treating one of the two can lead to a different prognosis of the epilepsy, for example, because at the moment, having a psychiatric disorder has important implication in terms of long-term morbidity, mortality, and also long-term prognosis. Identifying treatment and prevention strategies and also integrated care pathways are obviously important for the management of our patients. Thank you.
Thank you, Marco. I think for the sake of time, we'll move to the next speaker. But actually, please, everybody, put in any questions you may have to the Q&A button at the bottom of your screen. So next, I'd like to introduce Professor Arjune Sen, who's a professor of global epilepsy in Oxford, in the UK. And he is going to talk about predominantly epilepsy and dementia. Thank you very much.
Thank you very much, Helen, and thank you for this wonderful opportunity to talk to the International League Against Epilepsy on a topic that we all consider very important in epilepsy, and that's comorbidity. I've been asked to talk about a very specific area in cognition and Alzheimer's pathology, but we'll see how this interrelates both with what Professor Mula was talking about and what Professor Lattanzi will be speaking about in the third talk. Here are my disclosures. And an overview of what we're going to cover in the next 20 minutes or so is illustrated here. So we're going to look at how Alzheimer's disease and epilepsy interrelate, think about links, both epidemiological and pathological, look to other important intersections, and see if there are new directions we can move this field in, trying to leverage learning from epilepsy. So comorbidity in epilepsy is complex. This is illustrated here, and this was powerfully demonstrated in Marco's talk a moment ago. And there are multiple bidirectional relationships. We're going to concentrate predominantly on cognitive problems, which are here, although it is always important to take a very holistic approach to the people with epilepsy who you are seeing. And epilepsy, we always talk about it as the archetypal disorder of cortical networks. And this has been spoken about for a long time. It is reflected in current classifications about seizures. But actually, if we also look at the Alzheimer's and neurodegenerative field, well, they've sort of been saying the same thing, again, for a long time, saying that neurodegenerative disorders are large-scale human brain network diseases, and that's how they should be viewed and also treated. So with that in mind, I wanted to make the talk interactive. So if you could have a think about how long have we known that epilepsy and Alzheimer's disease commonly coexist? So how long have we known that epilepsy and Alzheimer's disease commonly coexist? Is it since before 1860? We heard about when epilepsy was first described in Marco's talk. Is it since 1910, since 1960, since 2010, since 2020, or is it just in the last 6 months? If you could vote now. So how long have we known that dementia and epilepsy coexist? So it's okay, so a few people thought very recently. The majority have thought sort of since 1960, and perhaps an increasing appreciation since 2010, and some saying since before 1860. It was a slightly meanly phrased question because Alzheimer's disease itself, so Alzheimer's defined the disorder in about 1907. This is Alzheimer with his laboratory. But you could argue that since that time, we've known that there might be an association. So Alzheimer's second patient, so this is Kraepelin illustrated here. So Alzheimer's second patient was a 57-year-old male who had progressive loss of cognitive function and developed seizures toward the latter stages of the disease. Affected family members were also included when they described the case. Mother, maternal grandfather, maternal great aunt, maternal great grandfather, 3 of the siblings and children of those siblings also all had progressive cognitive dysfunction. So this is a familial Alzheimer's disease manifesting with seizures. And as you can see, the patient was relatively young. So we have known for some time that these conditions coexist, really since the time of Alzheimer's. So if we've known that, well, how common are seizures in people with Alzheimer's disease? If you could vote once more, so how common are seizures in people with Alzheimer's disease? Is it 1 in 3 people with Alzheimer's disease, 1 in 6, 1 in 9, 1 in 12, or it depends? If you vote now. The 1 in 3, 1 in 6, 1 in 9, 1 in 12, or it depends, for how common seizures are in people with Alzheimer's disease. So it's a good medical answer to say it depends, because you can normally argue that. But in terms of how common, generally speaking, seizures are thought to be in people with Alzheimer's disease, it's about 1 in 9. But that may actually be an underestimate for all kinds of reasons, which we will allude to. But speaking to it depends, well, we just highlighted that Alzheimer's second case, his own second case of familial Alzheimer's disease, seizures were very common. Seizures seem to be common in that cohort. And if we look at people with a familial Alzheimer's disease, so this is early onset Alzheimer's disease, then seizures do seem to be much more common than in the general population. And obviously you can argue that at age 50 to 59, seizures are not that common. You can see here the instance of epilepsy across a lifespan. There's an inflection point at around 55 years. But people with familial Alzheimer's disease, early onset Alzheimer's disease, they've developed Alzheimer's disease between 50 to 59, they're nearly 90 times more likely to have seizures than an age-matched cohort. In the older population, epilepsy is still more common in that group, but it's about 3 times greater than the age-matched cohort in terms of the incidence of epilepsy. Crucially, and speaking to when we began to realize that epilepsy and Alzheimer's commonly coexist, it's not an epiphenomenon. You could certainly argue that prior to 2010, it was very much thought that if you had Alzheimer's disease, you were losing nerve cells through your hippocampus, you were likely to develop seizures, and that was an epiphenomenon. It's really now recognized that that's not the case. If you have Alzheimer's and epilepsy, you present with cognitive decline earlier. If you have Alzheimer's and subclinical epileptiform activity, you have earlier onset cognitive decline. If you have mild cognitive impairment and seizures, you present earlier. There was a systematic review a couple of years ago showing that baseline epilepsy associates with dementia and baseline dementia associates with epilepsy. Also, when speaking about how common seizures are, we recognize that there may be undetected seizures. Conditions such as amnestic wandering, which are often seen in people with Alzheimer's disease in nursing homes, for example, that is probably has an ectal and epileptic basis. Prolonged EEG recording can capture electrographic, subclinical, and even clinical seizures at times. And there has been work done with foramen ovale recording. The most recent is from De Vulder and colleagues, published in Brain very recently, which does detect epileptiform activity and seizures in people with a diagnosis of Alzheimer's disease. Interestingly, there is an association between generalized epilepsy and Alzheimer's disease as well. So this was published in Neurology last year. And this is a genetic epilepsy that seems to, again, predispose to cognitive decline in later life. And you can see there that things like inheritance of the ApoE4 mutation associates with subclinical epileptiform activity. And one thing we could consider is whether actually ApoE4, as well as being a gene for Alzheimer's disease, is also a gene for epilepsy. More than that, seizures can contribute directly to pathogenesis. So I was asked to talk about the pathology. So this is work from Jeff Nobles and his group from some time ago now, nearly 15 years or so ago. And this is the presenilin mouse. So presenilin is a genetic derivation for Alzheimer's disease. So if you have that mutation in a murine model and there are no seizures, well, there is some neuronal loss compared to controls. But if that model has seizures, you can see that there is quite significant neuronal devastation. So seizures seem to contribute to neuronal loss in Alzheimer's disease models. The animal models have shown that the ictal activity can be an upstream mechanism and contribute to cognitive deficits, that high levels of beta amyloid have in the brain which have been shown to associate with epileptiform activity. And importantly, again, illustrating the bidirectionality that Professor Mula talked about with psychiatric illness, reducing tau in an animal model of Dravet syndrome, a neurodevelopmental encephalopathy, reduces the frequency of seizures, tau being the hallmark pathology of Alzheimer's disease. This is an interesting case that I show quite frequently because it again shows how the epileptogenic pathologies and neurodegenerative pathologies can coincide. So this is someone who had refractory epilepsy, underwent a right temporal lobectomy, but continued to experience seizures, and at post-mortem was found to have an area of cortical dysplasia. But interestingly, when we stained that area for 88 phosphorylated tau, you can see that the phosphorylated tau ribbon only picks out the area of cortical dysplasia, not the adjacent cortex. So this is an internal control, and the tau is only detected in the area of a neuromigration disorder. Similarly, in that area, you can see tau tangles, and there is neuronal loss as well, which is not seen in adjacent cortex. So in terms honing in on the pathology a little bit, so hyperphosphorylated tau, the hallmark of Alzheimer's disease, has been shown to be present in temporal lobe resections from older people, and that increased tau correlated with decline in verbal learning. This was work that was done at the National Hospital in London about 8 years ago. More recent work has shown that there can be decreased GABA and increased ratios of chloride channels, NKCC1 to KCC2, suggestive of GABA depolarizing responses in people with Alzheimer's disease. And the corollary, if you look at epilepsy biopsies, you can find tau-like pathology, so neuropil threads and neurofibrillary tangles. So if we think about things more broadly, what other pathology do you consider the most important when thinking about epilepsy and dementia? So is it apoptosis? Is it excitotoxicity? Is it neuroinflammation? Is it synucleinopathies, or is it vascular disease? So we've talked about tau pathology, beta amyloid pathology. What other pathology do you consider most important when thinking about epilepsy and dementia? Apoptosis, excitotoxicity, neuroinflammation, synucleinopathies, or vascular disease? And if you could vote now. So if we look at those results, the greatest report was for neuroinflammation, excitotoxicity, about 25%, small number for apoptosis, small number for synucleinopathies, and about a quarter also said vascular disease. So all of them are important. All of these mechanisms can contribute to the intersection between Alzheimer's disease and the abbreviation that is shown here, later onset epilepsy of uncertain origin. So all can contribute. But if you were to think about what's most important, well, we have to try and disentangle that a little bit. And it's important to also say that things may change over time. You know, this is a graph showing Alzheimer's disease progression over time, and the pathology that applies does change over time. But with Alzheimer's disease and epilepsy, we'd probably argue that the most important other pathophysiological mechanism is vascular disease, and vascular risk can be very important in late onset epilepsy. This was work that was performed in Oxford by one of our doctoral students looking at epilepsy and vascular risk. And what the study shows is that if you have epilepsy, you have a very fast rate of cognitive decline, faster than people with stroke. But importantly, it's accentuated, that rate of cognitive decline, it can be accentuated in people with high cardiovascular risk. And of course, what that gives us is opportunity, because we can treat and we can target vascular risk to try and ensure that those curves more closely align. So the final poll relates to this case. So this is a case, many of you will have seen a case similar to this. It was a gentleman in his early 70s who was brought to the clinic by his daughter-in-law, and he had had events frequently at large family gatherings. So for example, on Father's Day or at Easter or Christmas, and there tended to be alcohol at those gatherings. And after a small nap, he would wake up and he would be extremely confused. Speech would be quite tautological and repetitive. And they had initially thought that this was related to the alcohol. He then had an episode that was a bit more dramatic when he was at his son's house, went into the son's bathroom and didn't recognize the son's bathroom, even though he'd been there many, many times before, and then became quite confused and a little bit agitated. It became clear in clinic that his real focus was on driving and why he wouldn't be allowed to drive, but that there had been also memory impairment and that there were vascular risk factors evident as well. And as you can see, this is the scan here, illustrating evidence of small vessel disease and quite marked bilateral hippocampal atrophy. So the final question is, what are your treatment options here? So are you going to initiate an anti-seizure medication? Are you going to start an antihypertensive? Are you going to start an acetylcholinesterase inhibitor, a statin? Are you going to advise lifestyle changes, such as stopping smoking? He wasn't a smoker, but would you advise lifestyle changes, or try and improve sleep quality, improve diet, for example, or all of the above? So what would be your treatment choice here? And so the vast majority, 84%, have said all of the above. So, and I think that that probably is where we would sit, because he's having seizures. Those episodes really are likely to be seizures. We need an anti-seizure medication. He's had more than one, and he probably has an underlying substrate, because that underlying substrate is likely dementia. So that would argue that there may be a role for an acetylcholinesterase inhibitor. You want to target vascular risk. I didn't mention his blood pressure, so we would need to check that before starting an antihypertensive. We definitely don't want to make things worse. It's always worthwhile trying to look at lifestyle and improve vascular risk from lifestyle, including sleep quality. So I think those answers were very reasonable. And why do we want to do all of this? Well, Professor Mula highlighted in his talk that psychiatric disorders can precede epilepsy, and the model of cognitive decline would currently suggest that there may be something, even if you develop epilepsy much, much later in life, that the set point might be slightly different. So here you can see that all of us, unfortunately, all of us, our cognitive ability declines with time. Here is this mild cognitive impairment is illustrated in green, and you can see here the curves related to epilepsy. So the early onset epilepsy, and then the later onset epilepsies, so are here. And you can see though that the set point is different. And what obviously we're looking to do is move the curves. So just like that work on cardiovascular risk accentuating cognitive decline in people with epilepsy, can you move this curve so that you cross the threshold for functional impairment later? Because that will have health system-wide benefits as well as benefiting the individual that you're looking to help. And what I really wanted to draw together right at the end was to say that we're not saying that there is one solution. What we are saying is that increasingly we recognize that hyperexcitability is an important part of Alzheimer's disease, that seizures and epilepsy can contribute to the pathogenesis of dementia. So there is this very deep intersection between a neurodegenerative disorder and epilepsy. But we know that epilepsy can be treated, and on top of that, we can try and mitigate vascular risk. There have been lots of papers that are beginning to explore anti-seizure medications to try and help cognition in epilepsy. We have been looking at levetiracetam, as have some others, but there are other papers, other pharmacological agents that are utilized in epilepsy are now being looked at to see whether they may actually offer improvement in people with dementia. And this, I think, offers a very exciting frontier that we should all be looking to leverage from. So in conclusion, mind-brain health disorders are a great global challenge, and we've talked here predominantly about dementia. We will be talking next about vascular disorders, and it's important to remember that populations are aging worldwide and are aging much more quickly, for example, in Africa, than they are in places such as the US, the UK, and Europe. I have demonstrated that there are significant intersections between epilepsy, dementia, and stroke. Management of vascular risk factors can be very important, and we're going to hear a lot more about that now. I hope I'm beginning to seed interest that anti-seizure medication in people with dementia may help stabilize neuronal networks to improve cognition. There is a huge amount to do there. And just as Marco mentioned in his talk, we have to have a comprehensive, holistic approach to comorbidities so that we can all age gracefully. Thank you very much for your attention. And I'm now going to pass on to Professor Simona Lattanzi, who has kindly joined us actually whilst she's on holiday. So I think that demonstrates commitment to the cause beyond what anyone could expect. She's in a lovely location in Italy, and we look forward to your wonderful talk, Simona. Thank you very much.
So thank you very much for the kind introduction, and thank you very much for the cordial invitation to take part to this e-forum. Yes, I'm on holiday, but it is absolutely a great pleasure to share all together some key points about the role of cerebrovascular comorbidities in people with epilepsy. And here are my disclosures, and here is the outline of my presentation. Sure. I will start with some key points, key messages about the prevalence of cerebrovascular comorbidities in people with epilepsy. Then I move to address the relationship between cerebrovascular comorbidities and epilepsy, and then we'll try to explain how epilepsy itself can be a contributing factor to cerebrovascular disorders. And then I focus on a very clinical and meaningful point, that is the relationship that cerebrovascular comorbidities may have in people with epilepsy in terms of the risk of drug-drug interaction. So let's start with some key data about the prevalence of cerebrovascular comorbidities. So what I want to show you the key results of a recent systematic review of studies that investigated the point prevalence of different comorbidities among people with epilepsy. More than 100 studies were included. And if we look at the different comorbidities, so we can see that the overall pool prevalence of stroke in people with epilepsy was 14.5%. But it is quite interesting to split this data according to the age of the people with epilepsy, because if you look at the adults with epilepsy, so their overall prevalence is less than 10%. But if you look at the older adults with epilepsy, so people age 65 years or older, so the prevalence is really, really higher, more than 35%. Another question is about what kind of cerebrovascular comorbidities is more common in people with epilepsy. And so in these studies, which compare different epidemiological data, so we can find that all types of cerebrovascular comorbidities, so both either hemorrhagic stroke or ischemic stroke or transient ischemic attack, are more common in people with epilepsy compared to the normal population. Another question is related to the role of cerebrovascular comorbidity in mortality. So we already know that there is an excess of mortality in people with epilepsy. So this is one of the many studies that address this issue. In these studies, specifically the cause-specific mortality rates in more than 9,000 subjects with epilepsy were compared with the mortality rates in the general population. And if you look at the different causes of death, so it was clear that there was a significant excess mortality due to cerebrovascular diseases in people with epilepsy, with a standardized mortality ratio of 5.3. So saying that the cerebrovascular comorbidity is absolutely really common in people with epilepsy, now I would like to try to explain how cerebrovascular comorbidity, and in particular how stroke can be a causing factor of epilepsy. So to try to address this point, I show you the results of a stroke register study performed in Sweden, which follow up for many years all people who had suffered from stroke and who had no prior history of epilepsy. And so after a mean follow-up of almost 5 years, so the rate of epilepsy defined as the occurrence of seizures at least 7 days after stroke was 7.3% in the overall cohort study. But if you look at the different types of stroke, so we can see that there are significant differences in the prevalence of post-stroke epilepsy in people with ischemic stroke compared to people who develop epilepsy after an hemorrhagic stroke. So the rate of epilepsy after ischemic stroke was 6.4, while the rate of epilepsy after hemorrhagic stroke was significantly higher, 12.4%. So we can surely say that post-stroke epilepsy is one of the most common causes of acquired epilepsy. And if overall 15% of all newly diagnosed epilepsy cases are due to cerebrovascular diseases, this rate is absolutely higher, almost 50%, if we consider people age 65 years or older. And post-stroke epilepsy usually develops within the first 1 or 2 years after stroke. And we can say that the number of people with post-stroke epilepsy is expected to increase in the future, thanks to the improvement in the management of stroke and the increasing number of stroke survivors. So the next question is, are we able to try to estimate the actual risk to develop epilepsy after stroke? And yes, the answer is yes. We have different tools that can allow us to predict the risk of epilepsy. The SELECT 2.0 score is a score which allows us to predict the risk of epilepsy after an ischemic stroke. And different components of these scores include the severity of stroke, the etiology of stroke, the occurrence of acute symptomatic seizures, or acute symptomatic status epilepticus, the involvement of the cortex, and the involvement of the middle cerebral artery territory. And so if you try to elaborate on this score, and so we sum up all the points achieved for each item, we have a total score. And according to this total score, we can stratify the risk of the patients to develop epilepsy over the next years. So just to give you an example, for example, if you look at the risk of epilepsy after 5 years after stroke for a patient with a SELECT 2.0 score of 0, so his risk or her cardiovascular risk of stroke of epilepsy is around 2%, while for patients with a SELEC 2.0 score of 10, so the risk of epilepsy at 5 years is more than 85%. And what about hemorrhagic stroke? So we have similar tools that can allow us to predict the risk of epilepsy after hemorrhagic stroke. One of these tools is the CAVE score, which is based on the cortical involvement, the age of the patients, the volume of the hemorrhage, and the occurrence of early seizures. And again, according to the total score, we can stratify the risk of epilepsy after hemorrhagic stroke into different classes. So for patients with a CAVE score of 0, the risk of epilepsy is less than 1%, while for people with a CAVE score of 4 points, so the risk is significantly higher, more than 45%. So once the diagnosis of post-stroke epilepsy has been performed, so the next issue is related to the treatment of people with post-stroke epilepsy. And so in this population, there are many challenges that we have to face. Usually patients are age more than 65 years, so they may have a decline in the organ function. They have the consequences of stroke as motor deficit or cognitive deficit. They may have very commonly vascular comorbidities, and so they are already taking drugs for treating these concomitant disorders. So if we look at an ideal drug, we would like to have, of course, a drug that is able to provide the seizure protection, that has a good tolerability profile, that is safe in patients with renal or hepatic failure, a drug that is safe in patients with cardiac diseases, a drug with no effects on the underlying vascular diseases that are very common in this kind of patients, drugs with no effects on the markers of cardiovascular risk, drugs with no relevant drug interaction, in particular with drugs used to prevent stroke in the secondary prophylaxis, as well as a drug with no or limited adverse neurocognitive effects. To tell the truth, we have very limited high evidence studies in terms of randomized control trials that evaluated the anti-seizure medication specifically in post-stroke seizures. One study compared levetiracetam with the carbamazepine, and one study compared lamotrigine with the carbamazepine. And so the main results were that no significant differences were found in terms of the efficacy and seizure freedom between the different drugs, but significant differences were found in terms of tolerability and safety. And so the occurrence of adverse events was lower for patients treated with the levetiracetam and lamotrigine compared to patients treated with carbamazepine. And also the occurrence of adverse events was higher for levetiracetam compared to lamotrigine. Another important issue is about the potential effect of the anti-seizure medication on the mortality risk in people with post-stroke epilepsy. This is the results of a nationwide register-based cohort study, which evaluated the risk of mortality in post-stroke epilepsy patients treated with different anti-seizure medication. And the main results were that both lamotrigine and levetiracetam were associated with a lower risk of cardiovascular death compared to carbamazepine in people with post-stroke epilepsy, while on the other side, valproic acid was associated with a higher risk of cardiovascular death compared to carbamazepine. So once the patient has been diagnosed with epilepsy, post-stroke epilepsy, and the treatment has been started, the next question is about the prognosis of this condition. So we already know that the response to anti-seizure medication in focal epilepsy is also related to the etiologies. In these studies, we can see in the blue column the rates of seizure freedom for different causes of epilepsy. And in purple dot, you can see the median drug load, which was necessary to achieve the complete control of seizures. And if you look at the different etiologies, so we can see easily that focal epilepsy due to ischemic stroke had the best outcome in terms of 12-month terminal seizure freedom. And further, the better prognosis in this condition was achieved with the lowest anti-seizure medication drug load. And so it is the time for the fourth question for you. I invite you to answer. And what is the overall rate of drug resistance among people with post-stroke epilepsy? Less than 5%, from 10 to 25%, from 30 to 45%, or no data still available in the literature. So please vote. Less than 5, 10 to 25, 30 to 45, or no data available yet. Okay, so the most prevalent answer is 10 to 25%, and I agree with this is the correct answer. So to tell the truth, however, we have very limited evidence in the literature which specifically focus on this issue. We have 3 major studies. In the first studies, the risk of drug resistance was evaluated in people with epilepsy after hemorrhagic stroke, and the rate was 22%. In the second study, all types of stroke were considered together, and the rate of drug resistance was 13%. And in the third studies performed in Italy, the risk of drug resistance was around 30% after ischemic stroke, and really higher, 28% in people with stroke after intracerebral hemorrhage. With the data that we have from these studies, we were also able to develop a nomogram to predict drug resistance in post-stroke epilepsy already at the time of diagnosis. So the variables that are related to the risk of drug resistance include the latency of post-stroke epilepsy, the occurrence of status epilepticus as the first clinical manifestation of post-stroke epilepsy, the severity of stroke, the occurrence of an hemorrhagic stroke subtype compared to the ischemic stroke, and the age at the stroke onset. The younger is the patient at the time of stroke, and the higher is his or her risk of drug resistance post-stroke epilepsy. But I'd just like to focus briefly the attention on the latency as a predictor of drug resistance. So this is the relationship between the latency and the drug resistance post-stroke epilepsy. So the latency is the time between the occurrence of a stroke and the development of epilepsy. And so it is clear that there is an association between the time from stroke to the occurrence of post-stroke epilepsy and the risk of drug resistance. And in particular, the risk of drug resistance is significantly higher when the onset of post-stroke epilepsy is within the first few months after stroke. Then this risk decreases progressively with a steeper decline over the first year after the stroke onset. So the next section of my talk is about the relationship between epilepsy and the cerebrovascular comorbidities. So how epilepsy can in some way contribute to stroke and cerebrovascular comorbidities. So this is a systematic review that pulled together population-based cohort studies, which evaluated the risk of stroke as well as myocardial infarction in patients with epilepsy. And again, I sum up the main results. So there was an increased risk of ischemic stroke, there was an increased risk of hemorrhagic stroke, and there was a gradient between the dose of the anti-seizure medication and the risk of stroke. So how can we explain these findings? So there may be an excess of vascular risk factors, for example, in people with epilepsy. We already know that subcortical small vessel diseases and other underlying occult vascular diseases can contribute to the epilepsy. But we cannot exclude the role of the anti-seizure medication because some of them may have a negative cardiovascular and metabolic effects. Just to go more deeply into this issue, so there is quite many, I would say many studies that already address the effect of the anti-seizure medication on the serological markers of cardiovascular risk as cholesterol, as C-reactive protein, as homocysteine, as well as the weight increase. And if you look at all the anti-seizure medication, we can generally say that all the enzyme inducers, strong enzyme inducers or moderate enzyme inducers, as carbamazepine, phenytoin, phenobarbital, all the valproic acid, that is an enzyme inhibitors, can have a detrimental effect on the metabolic and inflammatory markers. And there is also evidence that some anti-seizure medication may increase the risk of atherosclerosis. In these studies, patients who receive carbamazepine or phenytoin were followed up and compared with patients taking valproic acid and patients taking lamotrigine for at least 2 years. And all these patients were evaluated for the atherosclerosis risk in terms of the measurement of the intima media thickness of the common carotid artery. And the main results were that the long-term monotherapy with the carbamazepine and phenytoin as well as valproic acid caused significantly increase in the common carotid artery intima media thickness, while this effect was not observed in people treated with lamotrigine. So the last point of my talk is about the drug-drug interaction risk, which is absolutely a really important clinical point. Just to give you an overview, more than half of the stroke survivors are also living with hypertension, and more than 1/3 of stroke survivors are also living with one or more heart or circulatory diseases, most commonly heart fibrillation or heart failure. That means that patients with post-stroke epilepsy are usually taking other drugs for their cardiovascular disorders, and so there is the risk that drug-drug interaction may occur. And so to try to face with this issue, it is important to have in mind some key concepts about the pharmacology. So, of course, the interaction are usually due to the induction or the inhibition of the enzymes involved in the metabolism of the drug, as for example, the cytochrome, or to the induction or the inhibition of the transporters of the drugs, as the glycoprotein P. And so now I want just to give you a few examples about a clinically relevant drug-drug interaction that may occur between antihistamine medication and vascular drugs. So this is specifically a drug-drug interaction between antihistamine medication, phenytoin, which is a strong enzyme inducer, and nisoldipine, that is a drug used for the control of blood pressure. And so as you can see in this figure, so in people treated with the phenytoin and with nisoldipine, the levels of nisoldipine were significantly lower compared to the levels observed in patients, in control patients taking only nisoldipine, despite the dose of nisoldipine in phenytoin-treated patients was doubled. And so the concentration of nisoldipine were very low and detectable at many time points, so with clear potential consequences of the control of blood pressure. Another type of interaction may be due to the inhibition of the drugs. So this is the case, for example, valproic acid. In people treated with the valproic acid and the nimodipine compared to people treated with the nimodipine alone, the concentration of nimodipine are increased due to the inhibition of the drugs from valproic acid. And so again, this may have a clinical relevant consequences. Another class of drugs that usually people with post-stroke epilepsy takes are statins. And statins are affected by enzyme-inducing antihistamine medication through at least 3 different mechanisms. The first one is the induction of the cytochrome, mainly the cytochrome 3A4. The second is the induction of the glycoprotein P expression, and in both these cases, the result is a reduction of the concentration of the statins. And the third mechanism is the inhibition of the organic anion transporting polypeptides, which are transporters that extract drugs from the portal blood into hepatocytes for their metabolism. And so the clinical effect of this interaction is an increase in the concentration in the plasma of statins with an increased risk of toxicity. Another class of drugs that usually post-stroke epilepsy patients take are the oral anticoagulants. And so their interaction between enzyme-inducing antihistamine medication and warfarin are very, very well known, and possibly due to the induction of the cytochrome 2C9. And it is important to know that this type of drug-drug interaction may have important consequences also when the enzyme-inducing anti-seizure medication is withdrawn. Because in the case of the sudden withdrawal of the anti-seizure medication therapy, so the patient is put at an increased risk of bleeding due to the stopping of the inducing effects of the anti-seizure medication. And now is the time for the second poll, which relate to the direct oral anticoagulants. So for which of the following antihistamine medication, no relevant interaction with the direct oral anticoagulants are known or are assumed. lacosamide and lamotrigine, lacosamide and topiramate, topiramate and zonisamide, or carbamazepine and topiramate. Please vote. There are some new and some old anti-seizure medication. What do you think? Which are the best medication to use in people taking the direct oral anticoagulants? Very well. The most common answer is lacosamide and lamotrigine, and that is. This is exactly the point. So the direct oral anticoagulants in all four are substrate of the glycoprotein B, and some of them are substrate of the cytochrome 3A4. So it is clear that some interaction exists, mainly with enzyme-inducing medication on the enzyme inhibitors, while for some drugs, including lacosamide, lamotrigine, as well as zonisamide, no interaction are known or assumed so far. And so which is the potential clinical consequences of the use of enzyme-inducing anti-seizure medication with the direct oral anticoagulants? So again, there is evidence supporting that this type of drug-drug interaction may have a role, as shown in the studies that patients taking enzyme-inducing anti-seizure medication and direct oral anticoagulants are put at increasing risk of stroke, possibly due to a reduction in the effects of the direct oral anticoagulants. And so this is the last slide, and these are the conclusions. So we can say, which for sure, the cerebrovascular comorbidity is common in people with epilepsy. Stroke is a common cause of acquired epilepsy, mainly in the elderly age. People with epilepsy are at increased risk of stroke. The treatment of post-stroke epilepsy requires specific consideration related to the patients as well as to the diseases. The anti-seizure medication may have a detrimental effect on the cardiovascular risk as well as on the atherosclerosis risk. The newer compounds are generally to be favored because they are less prone to cause pharmacological interaction. Strong enzyme-inducing anti-seizure medication instead can enhance the metabolism of drugs used in the secondary stroke prevention, but it is important to know that clinically significant drug-drug interactions are usually preventable if we know what may happen when we combine two drugs together. And thank you very much for your attention.
Thank you very much, Simona. And if I can ask the other two speakers to kindly switch on their cameras and their microphones, we can thank you for 3 excellent talks with a range of different topics. We now have time for questions. And again, I encourage everybody to type their questions into the Q&A box with the button available at the bottom of your screen. And we've already had several questions. So I think the first one it's a little complicated, but I'm going to put it to Marco, if that's okay, because it came up for you. Knowing the reciprocal relationship between epilepsy and ASD, ADHD comorbidity, is it okay to provide a single DSM-5 ICD diagnosis of other specified neurodevelopmental disorder associated with epilepsy without including the other specific psychiatric diagnosis?
So thank you. This is a very interesting point of view. I would say that at the moment, no, for 2 reasons. One is a health management point of view, and the second one is clinical. As everyone knows, the ICD or the DSM in the US have implications in terms of medical reimbursement, medical claims, access to health pathways. So my concern would be for a group of patients not to have access to dedicated health pathways or public funding or insurance-based funding without the lack of a specific pathway. From a clinical point of view, unfortunately, we don't have strong data or robust data to identify this subgroup of patients with this specific comorbidity and how they differ clinically from the others. So in the future, I think it will be a reasonable aim, but now is too soon.
Thank you. There is an interesting question here, probably to the whole panel. What's your take on the burden of normality in epilepsy? I mean, this is something I've come across in the surgical population, that I understand by this, and correct me if I'm wrong, is the fact of the difficulty of patients to get used to lack of seizures and an improvement and a different change to their lifestyle or lifestyle requirements following surgery. But I just wondered what everybody else's take on that was. Who would like to start? I can see Marco nodding, but...
Yeah, I mean, this is what I take as well. It is the lack of skill set of someone that has always mediated the relationship with the world through a chronic condition with the lack of adjustment to the normal life. This is a very important point in order to have a good psychosocial outcome for our intervention. Identify these patients and supporting them with the correct rehab is definitely the most important thing, and conceptualize how making people seizure-free is sometimes not enough.
No. Thank you. Any comments from anybody else?
I'll comment briefly. I mean, I agree exactly with Marco had said. I think it's a really good question, especially for this topic, because it's the illustration that epilepsy is more than seizures. By definition, being rendered seizure-free following temporal lobectomy doesn't mean that epilepsy is solved, and there's a lot of psychosocial impact to discuss around that. So I think it's a really good question that we need to explore more going forwards.
I think this one's for you, Arjune, about a definition of early onset versus late onset TLE in relation to the presentation.
Yeah, no, thank you very much for the question. So conventionally, later onset temporal lobe epilepsy would be taken after the age of around 55 years. There are some moves to bring that forwards perhaps a little bit, but the inflection point in terms of incidence is at around 55 years. But it's quite a hard question because we were talking as well about conditions preceding the onset of epilepsy and when actually do the networks start to become unstable. But in terms of clinically, it's typically taken at 55 years, at around 55 years.
Thank you. And there's another question here, which is quite complex, but I think it's for you, Arjune. Due to cortisol's role and affinity with the hippocampus, is it possible to create a bidirectional relationship between cortisol release and seizures? And with the destruction of microtubules in Alzheimer's disease, how can we explain the increase of excitability in a seizure?
Okay, so we could spend the rest of the time discussing that. I think the cortisol, it's very difficult to really give a definitive answer on that. The interrelationship between steroids and hippocampal function is complicated. We know that steroids can actually be very good in terms of being an anti-epileptogenic agent, particularly in status epilepticus. You can create bidirectional relationships, but I think it would be very complex and requires a lot of disentanglement. With microtubules and hyperexcitability in related to seizures, again, that is complicated. We were at the ILAE meeting in Geneva a couple of years ago. There was an amazing talk on tau hyperphosphorylation, which has really frame shifted how we've looked at tau hyperphosphorylation and what is pathological and what is not pathological. Really, I think what's happening in all of these pathologies is there is you're creating instability within the neuronal network, within the cortical network, and the epilepsy is the end product of that if there is enough instability. But I think that there needs to be a lot of work on really trying to understand how the molecular mechanisms are working. There are plenty of molecules involved, like GSK3 beta, CDK5. Lots of things are being looked at and dynamin and other things related to microtubule stability. So great questions, and if the questioner would like to email me separately, I'm very happy to try and discuss that a little bit more.
Thank you, Arjune. I think this question's for Simona, although obviously others can answer. What is the opinion regarding patients with cardiac disease comorbidity and use of lamotrigine and lacosamide, considering they're both sodium channel blockers and possible effects on cardiac rhythm?
Yes, absolutely agree that all sodium channel blockers, not only lamotrigine and lacosamide, may have an effect on the heart rhythm. And so there may be some concerns in people with post-stroke epilepsy and cardiovascular cardiac diseases. So we all know the warnings for lamotrigine, and we also know that lacosamide, for example, is contraindicated in patients with a second-degree atrioventricular block. So sure, we have to evaluate the patients with post-stroke epilepsy for their cardiac function, and if some significant issues are found in terms of, for example, this arrhythmic problem or atrioventricular block. So I would like to prefer other classes of drugs as much as possible.
What are the thoughts about resective surgery in post-stroke epilepsy, if we consider that the epileptogenic zone is in the gliotic area? Now, as a pediatric neurologist, this would be a definite yes, but what's the general feeling about the adult neurologists?
Yes, I agree with the pediatric neurologist. Also for the adult point of view, it is possible. So generally speaking, the risk of drug-resistant post-stroke epilepsy is not so high. So usually patients are treated with the success, but some cases of drug-resistant epilepsy due to stroke, it is possible to start a pre-surgery workup, and if feasible, of course, the surgery is an option.
Okay, thank you. There's a question here about utilization of ketamine infusions for treatment-resistant depression in patients with epilepsy. Marco, have you got any views on that?
Okay, obviously it would be an off-label because it is not a recognized treatment. I would say that there is no evidence that depression is more resistant in people with epilepsy compared to the general population. So they have absolutely the same prevalence of the general population in terms of drug-resistant depression. So to be honest, there are a number of second-line, third-line options that can be used in people with drug-resistant depression that are licensed and can be used before. Also, the infusion of ketamine in epilepsy, we know it is used only in the context of refractory status, so not just simply for the management of seizure. So I would not encourage this practice at the moment.
Thank you. There's a comment here, maybe for Simona, because you had this in your talk. The interactions between levetiracetam and oral anticoagulants are based on animal studies. Are there studies in humans about this as well?
So thank you very much for this question that is really, really difficult to address at this point, because surely the first evidence came from the animal studies. And from the pharmacological point of view, the potential mechanism of interaction between levetiracetam and direct oral anticoagulants is related to the effect on the glycoprotein P. So levetiracetam would be an inducer of the glycoprotein P, and this may result in a reduction of the effect of the direct oral anticoagulant. So the first studies came from animals, but so far we have some evidence that accumulated also in human studies. I think that the problem so far is that despite we have different human studies, we do not have yet a definitive conclusion, because these studies are not consistent with each other. So there are some studies, both case reports or retrospective studies, which identify a clear relationship in terms of decreased levels of the direct oral anticoagulants and an increased risk of thromboembolic events, while other human studies obtain opposite results, with no effects on drug concentration and no effects on clinical endpoints. So I think that so far we have the answer to this really important question, because we know that how common levetiracetam is used in people with epilepsy in general. And so one suggestion at this point could be to use a drug monitoring of the direct oral anticoagulants in the setting where this is possible to be done.
Thank you. There is a question here about how safe it is to recommend anticholinesterase inhibitors to patients with epilepsy, and will symptoms become more frequent during this treatment? Anyone want to tackle that one?
Yeah, I think that's probably related to Alzheimer's disease. It's a good question because there has been a concern that acetylcholinesterase inhibitors, you can certainly find literature to suggest that that may actually lower seizure threshold. And I will throw it open to Simona and Marco as well, because I think though that the key thing to do if you have a patient with Alzheimer's disease and epilepsy is to work closely with your colleagues. So to work with your cognitive neurologists or your psychogeriatricians or whoever is doing the cognitive side more closely and work with them and have a discussion as to what may be appropriate, because there are also side effects from memantine and other medications that you might wish to consider. Also, we'd always say start at the lowest possible dose and up titrate gradually and watch very closely and be making one change at a time. So don't be changing the anti-seizure medications whilst you're changing the medications that might help with dementia. But I don't know whether Simona and Marco have any other thoughts on that.
Any other thoughts, either of you? No? Okay, all right. Okay. Simona, should we consider starting a prophylactic ASM in patients with a high select score?
So this is another very excellent question, which touch points where we have no robust evidence. So if you look at the only guidelines that we have so far, that are the guidelines of the European Stroke Organization or European Stroke Society, so they recommended against the use of any anti-seizure medication. So they are quite clear, but they do not address some important point from my point of view, that is the baseline risk of post-stroke epilepsy. And of course, we know that select score is one of the tools that we have to predict the risk of epilepsy. And I totally agree that if a patient has a select 2.0 score of 10, for example, so his or her risk at epilepsy after 5 years is more than 85%. So even if, to sum up, even if the guidelines play against the use of any prophylactic anti-seizure medication, I would say that in some circumstances, as in patients with a very high select score, or in patients who have already developed early seizures and the select score is very high. So I think that in this case, it is important to discuss with the patients about the pro and the contras about the starting a prophylactic treatment, because I agree that in some high-risk scenarios, it would be better to continue the treatment starting in the earlier phases.
Okay, thanks. Okay, this is a general question for everybody, and I know it has a lot of implications, particularly for the group of patients I look after. But someone's commented that an increasing number of research articles are being published with the motivation to offer solutions for personalized medicine, which is true. What's your opinion about their clinical use and implications in the near future with regard to the adult onset epilepsies? Maybe I'll go to you, Arjune, first.
Sure. I mean, no, thank you for the great question. I would say that to a degree, although it's not called personalized medicine, we should always be tailoring our practice to the patient in front of us. So personalized medicine is really derived from the genetics, that you would have a genetic answer in inverted commas, and then you would target a treatment according to that gene. But personalized or tailored medicine is what we should be doing all the time for everybody, and really taking a very comprehensive approach to dealing with the comorbidities, be they vascular risk, be they dementia, be they psychiatric comorbidities, or as we increasingly see all of this together, coupled with other reasons why certain medications you might be careful about, such as other comorbidities or drug interactions and so on and so forth. So I would think that personalized medicine is something we should all, in a way, be practicing. Genetic medicine and genomics is transforming the landscape, including in adults. I think the pediatricians have been way ahead of us in terms, certainly in the UK, I feel the pediatricians have been way ahead of us in terms of doing genetic testing very early, but that is now through Genomics England and the rollout of that, that is now coming in adult practice as well. And we're finding certainly that it's not common that we will identify a gene that will immediately change management, but we are identifying a lot of potentially pathogenic genes. So I think that tailoring your care appropriately is the way I would go.
Thank you. Well, maybe this leads on to this question, which I'm not sure is a question or a bit of a circular argument, and I'm going to put this to Marco, because someone's come forward to say, do we need dedicated brain health type clinics for our patients with epilepsy to identify and treat mental health vascular comorbidities? And I would have thought we all should be doing the same thing.
Yeah, no, this is a very good question, and there is now a lot of emphasis about brain health in general. And I'm definitely convinced that all of us can lead a brain health clinic in the context of our epilepsy clinic, because obviously giving advice to how to prevent comorbidities or how to live a healthy life despite having epilepsy should be part of our job. So I'm very convinced that, just to say that I fully agree with what Arjune said, in our clinics, we can very much focus on brain health as well. Prevention of cardiovascular disease, sleep, how to early recognize the mood and anxiety, how to direct patients to manage them as soon as possible and encourage them to live a healthy life.
Thank you. So we had another question here for Simona. We've got time now. Is there a concern about using an ASM, which is a PGP inhibitor inducer, combined with a direct oral anticoagulant?
Yes, absolutely. There may be some concerns because all the new direct oral anticoagulants are substrate of the glycoprotein P, and apixaban, edoxaban, and the rivaroxaban are also substrate of the cytochrome 3A4. So absolutely, there may be interaction that potentially may have a clinical relevance between enzyme inducers or inducers of the glycoprotein P with these direct oral anticoagulants, as whenever it's possible, it would be better to prefer other kinds of drugs with no known interaction.
Okay, thanks. And one last question. They're asking about the relationship between periods of mental illness exacerbations in people with epilepsy. Do we find that seizures are reduced in these periods? Almost like a forced normalization. So I suppose asking about the fluctuations we see in mental health in relation to seizure frequency.
Yeah, so the first normalization phenomenon is a phenomenon that has been described, is rare. It seems to be related to some areas on the brain that tend to suppress seizures, so rather than to a specific effect of a medication. So these phenomena exist. But in my experience, a relapse in mental health is often associated also sometimes with a relapse in the epilepsy as well. This is why when I explain to my patients the importance of discussing and addressing mental health when they are going to relapse, I always explain to them that when we have a relapse in the depression or in the anxiety, there are a number of chemical changes happening in the brain that may unfortunately trigger the seizures to come back, and we may sleep less, we may not forget to take our medications, and this is why it is important to address the relapse. So I tend also to explain to patients that unfortunately one drag the other down sometimes.
Thank you. Well, I think we're coming to the end of our time now, so I want to take this opportunity to thank all our speakers for their fantastic talks and the great participation in the panel discussion. I thank you also as participants for remaining to the end. You'll be asked to complete a short survey that will pop up when you leave this e-forum. It'll be really useful for you to complete this for our future e-fora. Tomorrow you will receive an email with details on how to access a self-paced virtual case to consolidate your learnings. Please keep an eye on our social media pages and our website for the ILAE to learn more about other educational events. Our next e-forum will be on the 23rd of September, Reducing Epilepsy-Related Mortality, Emergency Treatment, Effective Management of Status Epilepticus, and improving our understanding of SUDAP. This particular e-forum, the one you've just listened to, will be available on demand in about a week. So on that note, I wish you a very pleasant rest of the day, morning, overnight, wherever you might be. Thank you for your participation and look forward to seeing you in the future.